samfélagsins. Dæmi greinar sem hafa verið birtar niðurstöður rannsóknarinnar eru til dæmis ein sem kallast Relationship of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Death in Adults. Önnur grein kallast The Origins of Addiction, Evidence from the Adverse Childhood Experiences Study. Þeir sem hafa áhuga á að fá þessar tvær greinar senda rafrænt ásamt lista yfir greinar niðurstöður rannsóknarinnar geta skráð sig á blöð sem munu ganga hérna salinn á meðan á fyrirlesturinn stendur. Einnig hægt að krossa við að vera á póstlista miðstöðvar foreldra barna til að fá upplýsingar fræðslu sem verður haldin á vegum miðstöðvarinnar í framtíðinni. Að lokum langar mig að vekja athygli á útskriftarsýningu ljósmyndaskólans sem opnar þann 28. janúar næstkomandi í Læknasafninu á Seltjarnarnesi. Þar verður meðal annars sýnt verk eins ljósmyndanema sem kallast Hinn þögli faraldur. Verkið sýnir ljósmyndir og teikningar og gögn úr sjúkraskýrslum og sálfræðiskýrslum þar sem rauði þráðurinn að ofbeldi og misnotkun hefur átt sér stað. Ég tel að þetta geti verið áhugaverð sýning fyrir þennan hóp sem hér situr, þar sem efni fyrirlestursins í dag kemur þar við sögu á mjög persónulegan hátt, þó að efnið í verkinu sé ekki persónugreinanlegt. En þá ætla ég ekki að hafa þessi orð fleiri og hleypa Dr. Felitti að. So now, Dr. Felitti, the floor is yours.
Why, thank you. I'm delighted to be able to visit you, and I still marvel at how this is possible to do electronically this way. What we'll be talking about is a very large study that has been going on here for the past 20 years about how what happens to people as children has such a profound effect on what happens to them as adults, including the development of various diseases and even their life expectancy. In a way, you could symbolize what we're talking about by these two photographs up on the screen. If someone gave you this newborn infant with its extraordinary potential and said you had 19 years to develop that individual into the person lying unconscious on the sidewalk in downtown San Diego, what would you have to do? How would you do that? It's an ugly question that most people don't like to think about, but it has enormous implications socially, medically, economically. And that's what the ACE study is really about. One of the things that we discovered in the ACE study is that the public health problem that we commonly see is often some individual's unconsciously attempted solution to problems about which we keep ourselves unaware. And I will show you repeatedly evidence for what that looks like in everyday life. The implications of all of this for prevention and for treatment are major. So on the next slide, I will summarize for you what we learned in the ACE study and then go on to show you the evidence for it. That adverse childhood experiences, and I'll define them shortly, are very common and very disturbing, and because of that, are mostly unrecognized. They turn out to be powerful predictors of adult social malfunction, of emotional distress, of health risks, disease, and strongly of premature death. And that combination makes them the leading determinant of the health, social well-being, and economy of the nation. The next slide shows the patient who really brought this all about in 1985 and began to change our thinking on these issues dramatically. We were running a major obesity program here in San Diego using the new technology of supplemented absolute fasting, which allows one to accomplish major weight loss. So this woman came in at age 28, weighing 185 kilograms, and we reduced her weight from 185 kilograms to 60 kilograms in 51 weeks and exposed the real problem. I remember when she came in, she asked us if we could help her with her problem. And our first mistake was in accepting her diagnosis of what the problem was. So we put her in the program and reduced her weight by this massive amount. And only years later did we discover the little photograph on the left side showing her at age 8, which really forces you to ask yourself, my God, what happened between those two? Otherwise, it would be all too easy to look at the big photograph and say, well, some people are just born that way, etc. The next slide shows her weight curve. It really looks like an Olympic ski jump. She comes down from 185 kilos, gets way down, and then stays there for a couple of weeks, and in a short period of time has a major regain. I couldn't believe how much she regained just in the first 3 weeks. And in a short period of time, shorter than it took to lose the weight, she's back to where she started originally. And with that huge weight gain in the 3-week period initially, I remember asking her, what's going on? And she said, I think I'm sleep eating. What do you mean? Well, when I was a kid, I used to be a sleepwalker, she said. I haven't done that for years, but I live alone. And when I go to bed at night, everything's clean and put away in the kitchen. I wake up in the morning, boxes and cans are open, pots and dishes are dirty. Somebody's obviously been cooking and eating there. I'm the only person there. I guess that's what's happening, but I have no recollection of any of this. Okay, I never heard of it before, I said, but it's got a certain force of logic to it. But why now? Why did this happen now? Why not 2 years ago? Why not 5 years from now? Why now? I don't know. But what do you think? I don't know. I understand, but why do you think now? Why not some other time? Yeah, you said that. And on the third pass, she stumbled and said, well, actually, there was this man at work. He was a much older man, you understand. He was married. And he said to me, hey, Patty, how do you like, you're looking pretty good. You lost all that weight. How do you like to make it every week with me? American slang for having intercourse with me. And that was the day the sleep eating began. And I remember thinking, well, that's a pretty clumsy proposition. But this is 1986. It is Southern California. It's a pretty extreme response. Why the extreme response? And in pursuing why the extreme response, in several minutes, she was telling me about having a lengthy incest history with her grandfather, who had been having vaginal intercourse with her from age 11 to age 20. And I remember naively thinking, wow, this is the second incest case I've seen in then 23 weeks and 23 years of practice. Even her job made sense. She was a nurse's aide on a night shift in a nursing home. In other words, her job was to stay awake and on her feet all night long to make sure the old people stayed safely in bed. Well, about 10 days later, I guess that lowered the threshold for me because I ran into another childhood sexual abuse case. And I was so surprised by that I decided to inquire routinely of everybody coming into our obesity program. And I was really surprised then because it seemed that every other person that I was talking with, that I was asking, was acknowledging a history of childhood sexual abuse. And I remember thinking, I mean, it can't be, people would know if this were true. Someone would have told me in medical school, wasn't that what it was for? 186 patients later, it turned out not to be every other patient in the obesity program, but 55%. I still had a little bit of doubt, but I was getting, pretty much to believe this was real, but nobody wanted to hear about it. I asked 5 colleagues to interview the next 100 patients consecutively coming into the obesity program. They turned up the same thing. In addition, you'll see on this next slide, in addition to childhood sexual abuse, as we pursued that question with patients, we began to hear many other stories from patients. It was really quite extraordinary. And here are the 10 most common categories that we learned in this very middle-class population. The population really pretty much like you and me. Almost exactly half men, half women, 80% white, including Hispanic, 10% black, 10% Asian, 74% had been to college, average age 57, etc. And the question then came up, well, if this is so common in our obesity program, does it exist anything like this in a general population? And if so, how does all of that play out over time? So that was what led to the ACE study. And presumably you will have had a chance to look at some of these 10 categories of adverse childhood experiences that we studied. They're not the only 10 in the world, obviously, but they were the most common 10 in a very middle-class population, 74% of whom had been to college, etc., all of whom had really high-end medical insurance. The 10 most common in a population pretty much like you and me. Believe me, this was a huge surprise, but you'd have to ask everyone routinely to find that out. And of course, we have all been taught as children that nice people don't talk about certain things, and my God, surely don't ask questions about them. Anyway, this is what led to the ACE study, to find out how common these were in a general population and how they played out over time. So here's the outline in the next slide of the ACE study. We had a very unusual department of preventive medicine here in San Diego, where we provided unusually detailed medical evaluation, medical examination to 58,000 adults a year in one setting. And that would be symbolized by the dark blue box in the center. So we spent the next 2 years planning how we were going to do this. I was by then working with people from the Centers for Disease Control, a major government agency, the CDC, perhaps you've heard of it in Iceland. And we designed a study that would have 26,000 people in it to look at how life experiences in childhood and adolescence would play out in adult life. So we asked 26,000 consecutive people coming through. This had nothing more to do with obesity. This now was a general population. And 17,337 agreed to cooperate with us. And so we asked them detailed questions by a very lengthy paper-based questionnaire filled out at home that we then pursued further in the exam room. They underwent, in the blue box, a very detailed medical history, detailed physical examination, extensive laboratory studies, and we compared their current health status there at average age 57 to what had happened to them growing up roughly a half century earlier. And then we followed them for the next 20 years, comparing what happened 50, 60, now 70 years ago to current pharmacy costs, emergency room visits, doctor office visits, hospitalizations, and death. So that's the design of the ACE study. We have just passed the 20-year mark in the follow-up portion of the ACE study. We were dealing with mountains of information, and one of the things that we needed to do was simplify things in a way. So on this next slide, you will see how we created the ACE score. The ACE score was the sum of the number of categories of adverse childhood experience, not events, but categories. So if you grew up with, let us say, an alcoholic and a drug user in the same household, that was simply 1 point for the category. If you were molested multiple times, that was simply 1 point for the category. And so in this very middle class population of 17,500 middle-aged, middle-class adults, 33% claimed no experience with any of the 10 categories. 67% acknowledged experience with one or more. And as you'll see, 11%, 1 in 9 people, acknowledged 5 or more of the categories. So we saw that if any category was present, there was an 87% chance that at least one other category would be present, and a 50% chance that at least 3 others would be present. And we saw that women were 50% more likely than men to have a score of 5 or higher. Much to our surprise, we found that the damaging effect of the categories was essentially equal. Believe me, that was a big surprise. But on the other hand, at every turn, we were running into something that we didn't know or would not have expected. So what does this look like in the office every day? Well, this is a very interesting man here. A quite bright guy, actually, but an isolated sort of person. When he was 2, his parents divorced. He never saw his father again. When he was 5, his mother remarried. And for whatever reason, his stepfather saw fit to beat him pretty much every day. When he was 8, he tells me he remembers going to school one morning and realizing nobody is ever going to be there for me in my life. When he's 20, he comes home one day and finds his stepfather beating his mother. And impressively, he attacks his stepfather with a heavy iron frying pan, produces a skull fracture and 5 long bone fractures, is imprisoned for attempted murder. Ultimately, he gets out, becomes a good citizen, and he works on major construction projects that keep him away from home most of the year. And we came to see that for him, home had dangerous memories. In another era, this guy might have been a cowboy, or in current times, maybe working on an oil rig out in the ocean. But listen to what he has to say. He's a very heavy smoker. He's a very heavy drinker and a heavy user of the street drug crystal meth or methamphetamine. Listen to what he has to say about the benefits of addiction. We don't ordinarily think about this.
20 to 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Gotten rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
In keeping the door closed too.
The memories that I've blocked out with all these years with the alcohol and the drugs.
So you see what's happening to you now as related to what happened to you decades ago.
Yep. I found a way to block the emotions and the memories.
With
drugs, alcohol, cigarettes.
So he's talking about the functional benefits of what we ordinarily call dysfunctional behavior. He's talking about our three most common addictions. Addiction being the unconscious, compulsive use of psychoactive materials or agents, as we have up here in this next slide. Or, in plain talk, it's hard to get enough of something that almost works. Well, maybe the next mouthful is going to do it. Or give me another cigarette. This is, I need a little more. Another drink. Yeah, I'm not ready yet, etc. Or maybe the next, well, surely the next one is the one who's going to love me. And if not, well, surely the one after that. So the conventional view is that addiction is related to characteristics that are intrinsic in the molecular structure of some substance. When I was a kid growing up, I used to hear all the time, you take heroin enough times and you're not going to be able to stop. I believed it because everybody said that. What we found in the A study was that addiction highly correlates, as you see here in the next slide, highly correlates with characteristics intrinsic to that individual's childhood experiences. The strength of this relationship is extraordinary, and the implications of this for prevention and for treatment programs are profound. Two important studies are out, one by a woman named Lee Robbins, who studied American soldiers in Vietnam during the Vietnam War. And she met with 900 American soldiers who acknowledged to her, but not to the Army, that they had used heroin daily for the past 30 days. She then met with them 8 months after they returned to the United States. No treatment because none of this was officially recognized. She met with them 8 months later after they're back home, and incredibly, 94% of them are no longer using heroin with no treatment. This was really extraordinary. The animal version of this experiment was carried out in Canada by a psychologist named Bruce Alexander at the University of British Columbia. He had a nice rat room. Each rat had their individual cage, nice air-conditioned room, 3 square meals a day, etc. well, most of us would have thought, no, really treating the rats well. We missed the point, however, that each of those cages had a solid wall. So those animals never saw for the rest of their lives a creature who looked like them. In other words, they were in solitary confinement, in total isolation. And he gave each of them 2 bottles in their cage, one of plain water and the other with water with heroin. And all of the rats ended up drinking water with heroin. Now, most people would assume, well, it goes to show the heroin is addicting. He was more insightful, however, and realized that these rats were under enormous stress, even though superficially we were thinking that they were well treated. And so he created Rat Park, an outside enclosure filled with dirt and rocks and trash, and put the addicted rats in there. Again, the same choice of water and water with heroin, except now they're running around together. And amazingly, the rats who had been, quote, addicted inside all ended up choosing water. So the implications of this are really quite dramatic. Let's look now at more common forms of addiction, smoking. Next slide here shows, well, I don't know what it's like in Iceland, but in San Diego, it's very difficult to smoke comfortably in a lot of places. You can't smoke on a public beach. You cannot smoke in the county park. My God. And in spite of that, although there was a big drop in smoking initially with the discovery of its relationship to lung cancer several decades ago, there really has been no decrease in smoking in the United States in roughly the past 12 years, in spite of ever increasing public health pressure against it. And so what we saw here when we looked at current smokers in an environment notably hostile to it is a very clear relationship of underlying ACE score to the likelihood of being a current smoker in an atmosphere notably hostile to it. So-called dose response effect. As the ACE score went up, the likelihood of being a smoker went up. Isn't that interesting? Isn't that interesting? Now, think about it a minute. The benefits of nicotine have been known for some time. We don't speak of the benefits of nicotine ordinarily, but it has notable benefits. It's got notable risks too, but the risks are way out in the future. The benefits occur within 15 or 20 seconds of inhalation. It has anti-anxiety activity, antidepressant activity, appetite suppressant activity, and as the American Indians figured out centuries ago, anger suppressant activity. That's why they used burned tobacco in their peace pipes, not moss or oak leaves. So the benefits are real in 15 or 20 seconds of inhalation. The risks are very real also, 15 or 20 years away. In the next slide, we look at the relationship of underlying ACE score to self-acknowledged alcoholism. This is not our diagnosis of alcoholism. This is the patient's. We asked the question, have you ever considered yourself to be an alcoholic? And you see a very clear relationship of self-acknowledged adult alcoholism to underlying ACE score. Isn't that interesting? Sit down, have a drink, relax. Well, some people need a great deal of relaxing. The benefits are, again, immediate when they're needed. The risks are very real, but in the distant future. We looked then at self-acknowledged injection drug use on the next slide here. And what you see is really interesting, because at A score 6 or more, which is not on the slide, because it is so massively increased that it distorts the rest of the slide into unrecognizability. At A score 6 or more, the likelihood of being a self-acknowledged injection drug user is 4,600% greater than the likelihood for an A score 0 individual. And I remember epidemiologists at the CDC telling me that those were numbers, the magnitude of which they see once in a career. You know, you read in the newspaper something increases breast cancer or prostate cancer by 30%, and everybody goes nuts. And here we're talking 4,600%. Isn't that interesting? Well, I don't know what the case is in Iceland, but in the United States, the most common street drug is methamphetamine, known as crystal meth here. Everybody knows that. Everybody knows how dangerous crystal meth is, bad stuff, etc. Interestingly, no one seems to recall that the first successful prescription antidepressant introduced for sale in the United States in 1940 by Burroughs Wellcome and Company was methamphetamine. The very same chemical on the street sold an unknown dose in impure form as crystal meth. Wow. Wow. Does this matter? Well, dose matters a great deal with any medication. If you double the dose of your digitalis, you'll be dead in about 10 days. If you take 30 aspirin instead of 2, you've taken a suicidal overdose, etc. So does this matter to our treatment of any of the addictions? Do you think we should focus on the underlying causal issue? Or do we continue providing empty advice that what's being done is bad or unhealthy, especially when we see that that doesn't work? Here on the next slide is an advertisement for the highly successful new prescription antidepressant full-page ad in 1942 in the Journal of the American Medical Association. The very same stuff in impure form and unknown dose, key point, sold on the street as crystal meth. The idea of dosage is extraordinarily important in terms of the safety of any chemical. Let's go back to some patients now. In the next slide, you'll see a man who became obese as a child after his parents divorced, and he was sent to live with his violent alcoholic grandfather so his mother could work. And he vividly recalls eating for solace, as in our phrase, comfort food. And as he grew obese, he discovered that obesity offered advantages. We know that at some level, but think of our use, at least in American English, throwing your weight around. But it's easier to blame McDonald's for why kids get fat. But McDonald's, as you'll see, is really an intermediary mechanism that's needed by some. When you explore this carefully, you find that the relationship of childhood obesity to parental divorce is very impressive if you routinely inquire about the age when weight gain first began. Actually, that's the single most important question in the treatment of obesity. So let's listen to what this man has to say. He's just lost 158 pounds in the program. The real question, of course, is why did he ever gain it in the first place? Listen to what he has to say.
It wasn't that I ate because I was hungry. You know, it was, when I look at it, it was just a place for me to feel safe. As a child, I remember there was a point, I would probably say, all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, didn't happen.
Around the same time that he was in the program, we had two men in the program who were guards at the state prison downtown. They lost between 100 and 150 pounds each. Very major weight loss. They were very clear about not being comfortable walking into the prison at their reduced weight. They felt a lot better going in looking big as a refrigerator. Again, think of the expression, throwing your weight around. In the next slide, we'll see a woman's view of these things. This was somebody who was extensively molested as a child. She ate to feel better and then realized that obesity reduced sexual attention. Again, we see that what may be viewed by public health as a problem may be viewed by the patient as a solution, which has a lot to do with why certain problems are so difficult to treat. We're not treating the problem, we're treating somebody's attempted solution. Let's listen to what she has to say.
Ella H. started the interview by spontaneously commenting on the threat she felt when her psychiatrist recommended bariatric surgery to treat her obesity, and offered to sign the necessary paperwork to have Kaiser Health Plan pay for the procedure.
Can I get comfortable first? And then he says, no. He says, when drug addicts come, we take them off of drugs first. And he would take me off of my drug. Food was my comfort food. I cope with life with food. And it's really strange tonight. I guess the Prozac's helping, because when I'm taking the Prozac, I will lose a little bit of weight. And I just feel that he was taking away my safety. And so I decided not to even bring the paper to the doctor and have it done, because I'm not ready, I don't think, to get the weight off and know that I can't gain it back and can't be safe again.
So what we learned from our patients was really quite extraordinary. The next patient is a woman who was extensively molested as a child once again. She compensated by smoking 3 packs a day. And she explained to me that smoking 3 packs a day creates a cloud around oneself that keeps people at a certain distance. I had never thought of it that way. And she was slender. At age 35, her husband convinced her to stop smoking for her health. Without the smoke barrier, she was receiving a lot of male sexual attention. She was not capable or comfortable dealing with that, didn't know what to do. She ate to reduce her nervousness. She began gaining weight, a great deal of weight. And soon she weighed 140 kilos. And at that point, she went into respiratory failure because the lung damage that she had been able to handle when she was slender, she no longer could handle when she weighed 140 kilos. So she came into our weight program and we reduced her weight to 68 kilos, and she no longer needed the oxygen, and we thought that was wonderful. However, at the reduced weight, male sexual attention once again came into the forefront, which was very frightening to her, and she consciously chose to regain the weight and accept the fact that she would be on 24-hour-a-day oxygen for the rest of her life. Listen to what she has to say. It's really quite memorable.
You supplied me recently a lengthy autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. Took us a long time to figure that out here, and you just casually dropped that as though, of course, anyone knows that. So you are in respiratory failure on 24-hour-a-day oxygen.
Yes.
Major amounts of weight, overweight.
Yes.
And you demonstrated, or we demonstrated together a couple of years ago, that when you had a major weight loss in the OptiFast program here, that your need for oxygen disappeared.
That's correct.
So that, if you lost 150 pounds approximately, the need for oxygen would no longer be there. The weight came back. Most people have very little understanding of why people get fat or regain. I mean, they're stuck with this simple belief, don't you know it's bad for you, etc. And people tend to know even less about smoking.
Yes.
It's labeled an addiction, and as though that somehow explains it all.
Right.
Etc. And you make this extraordinary statement about what we perceive as the problem really being the solution. Can you explain more about that?
Yes. I think I've come to that conclusion. It hasn't been quite immediate. It's come to me over the last few years of analyzing just exactly where I've been and what I've done. Obviously, I was a 3-pack-a-day smoker when I was thin. I didn't have a weight problem until after I was 35. But I've done several OptiFast type things, and I finally came to the realization on my own that the reason I put the weight back on was to protect myself.
Well, we've been hearing this again and again. Maybe there's something to it. She soon began talking, as we'll see on the next slide, about her chronic depression. Most people speak of depression as a disease. Many say it's genetic. Some say it's due to a chemical imbalance in the brain, and there's something to be said for each of those. But here is a different idea to think about. What if, on the next slide, depression were not a disease, but a normal response to abnormal life experiences? Here you'll see what we found when we looked at self-acknowledged chronic depression, next slide, and its relationship to underlying ACE score. ACE score of 4 or higher, chronic depression, as you'll see in the red bar, exists in almost 60% of women and 35% of men. We looked further into this, as you'll see here, in terms of suicide, and attempted suicide is very dramatically related to underlying ACE score. At ACE score 4 or higher, the likelihood of attempting suicide is almost 20% at some later point in life. Now, interestingly, ACE score 6 or higher does not fit on the graph again without massively distorting everything. At ACE score 6 or higher, the likelihood of attempting suicide later in life is between 3,100 and 5,000% greater than it is at ACE score 0. These are extraordinary numbers, and the relationship to underlying ACE score to what happened in childhood is really remarkably strong. On the next slide, you'll see the relationship to rape. This was really a surprise. How does what happens to a little girl affect the likelihood of being raped later in life? You'll have a chance to ask me questions, but that's what I want you all to think about, because the answers to it have relevance to far more than just rape. We looked at the relationship you'll see here of ACE score to hallucinations. Now, to get this information, you'd have to ask everybody if they hallucinate. And most of us, as I said before, have been taught as children that nice people don't talk about certain things, and my God, surely don't ask about them. But when you do ask about them, you find that at ACE score 7 or higher, 10% of the people acknowledge a history of hallucinatory activity. And because we thought, well, some people would be saying, yeah, but I mean, at ACE score 7, people are going to be using alcohol or drugs to try to feel better, and that's why they're hallucinating. So we corrected for alcohol and drugs in the pale slides, and you see essentially the same relationship. Here in the next slide, you'll see what happens when we looked at promiscuity, which we defined as having 50 or more lifetime sexual partners. A clear relationship to underlying ACE score. Well, maybe the next one is the one who's going to love me, and if not, well, surely the one after that. In the next slide, you'll see the relationship to unintended pregnancy or elective abortion. And what we found was that, like most accidents, they're not totally accidental. But interestingly, when we were looking into this, we found a relationship of ACE score to miscarriage of pregnancy. Well, now we're beginning to move into a medical realm. How do you get from life experiences as a little kid to miscarriage of pregnancy a couple of decades later in life? Well, as we go into this, we found, as you'll see here on the next slide, that there are 3 pathways to go from ACEs to disease, to go from life experiences in childhood to disease in adult states. The first pathway is through various coping mechanisms. overeating, heavy drinking, smoking, drug use, etc., to feel better. And their long-term consequences. Okay, that's easy enough to understand. But now we're going to move into a more complex issue through complex stimulation, chronic stimulation of the central nervous system. Chronic stimulation of the brain from chronic, unrelieved major stress. We'll see how that works in a moment. And the third category is by something called epigenetic effects, the effects of environment on gene function, not on gene structure. Affecting gene structure would be called a mutation. This is like putting an on-off switch on a gene. It's a very important and rapidly expanding field. We did not study this because when we put the A study together years ago, the word barely existed. The field has grown explosively, and you'll be reading about epigenetics in the papers soon enough. So let's go to the next slide, and you see the relationship that we found of liver disease to underlying A score. Well, when we saw that, okay, yeah, gonna inject street drugs and get chronic hepatitis from dirty needles and so forth. Yeah, okay, so we thought. Well, that was the beginning, but only a partial answer. We next looked at the relationship of A score to heart disease. And on the next slide, you'll see this was really interesting. Ever since the Framingham study, we have all known about the relationship of heart disease to cholesterol, to obesity, to diabetes, to smoking, to high blood pressure, etc. And most of us have forgotten that about 12% of people with heart disease don't have any of those recognized Framingham risk factors. When we looked at them, people with heart disease but none of the conventional risk factors, we found that in them, underlying A score had a major role. How does that work? Well, in recent years, it's been discovered that one of the effects of chronic major unrelieved stress is the hyperstimulation of certain areas in the brain that cause the release of pro-inflammatory chemicals that cause inflammatory changes in the lining of blood vessels. In the very smallest blood vessels, the microscopic blood vessels, that causes the blood vessels to shut down totally and turn to scar tissue. What little piece of organ they had been supplying blood to. Our first patient, Patty, died at age 40 of pulmonary fibrosis, a condition where her lungs turned to scar tissue. Never a smoker, no exposure to air pollution. In larger blood vessels, these inflammatory changes of the lining act like a magnet, attracting the deposition of cholesterol from blood as it passes by, even from blood that has normal or low levels of cholesterol. The effect is that it causes cholesterol plaques to occur. Really remarkable experience here. When we looked at smoking, we found that at any given level of smoking, the likelihood of chronic obstructive pulmonary disease, emphysema, increases with an underlying A score increase. And this too has recently been discovered to be related to the effects of pro-inflammatory chemicals. So these effects are more difficult to understand, but our recent discoveries have provided us a new understanding here. This is a very interesting book on the next slide, written by a woman remarkably open and forthright autobiography. You can look it up on Amazon. Heavily molested as a child by her father, who'd had intercourse with her for many years, who also used to bring her into saloons at night and sell her for sex to strangers. Somehow she did not commit suicide. She did not become a mass murderer. Somehow she graduated from high school. And around that time, the county discovered all of this and took her from her family and put her with a foster family. And they helped her get into college. And she graduated college, got into law school, graduated law school, and ultimately became a United States federal judge. That's a very big deal. It would be easy to say, isn't it wonderful how resilient this lady was? Well, that's a reflection of how superficial our assessment of resilience is. Because resilience we usually assess by looking at how much money somebody's earning, whether they have some sort of well-accepted social position or academic position. We totally forget that a big part of resilience is biomedical. This woman has had 5 different kinds of cancer. I had never heard of that number before. 5 different kinds of cancer and 2 autoimmune diseases, multiple sclerosis and lupus. Well, how does one go from childhood experiences to 5 different kinds of cancer? Initially our thought was, yeah, you smoke 3 packs a day, of course. Well, this woman never smoked. And that wouldn't give you 5 different kinds of cancer in any event. Well, actually, we've known pieces of the answer for some time, but just never put it together. We all know that if a person needs an organ transplant, that they have to be on immunosuppression medications for the rest of their lives so they don't reject the transplanted organ. Some of you will have correctly heard that one of the risks of lifetime immunosuppression is an increased risk of cancer. But on the other hand, if you're going to die next week of kidney failure and, maybe get cancer in 15 years, most people will accept the kidney transplant. That's because all of us are forming at a low level cancer cells every day from various organs, some of which you've never even heard of. And our immune systems recognize those cells and simply destroy them, and we never know the difference. So getting cancer means either that the rate of production of cancer cells is massively increased beyond the level where our immune systems can handle it, or our immune systems are suppressed so they cannot even handle the low level of cancer cell production that occurs normally in all of us every day. Well, in recent years, once again, it's been discovered that one of the effects of chronic major unrelieved stress is immune system suppression. So we were really moving into uncharted territory, and this next patient will provide us an example of what this looks like. This is a woman who's articulate, well-dressed. She holds a significant position in a big university. She's obviously doing well and just the kind of person from whom we'd not seek an abusive childhood history. Of course, we'd skip that kind of questioning for our own comfort, but we'd be smart enough to say we didn't see any need to risk upsetting a patient who's doing so well. So listen to what she has to say.
Can you tell just by looking at me that I was an abused child? Can you tell that I was sexually abused routinely, that I was neglected, starved, beaten? Probably not. You would have to ask in order to find out, and that's not the sort of thing that people typically ask about. The downside of having this kind of childhood is that it translates into health problems in adulthood. At least in my situation it seems to have done. I'm now recovering from my third battle with cancer. Not the same cancer, 3 different kinds of cancer. I've had chronic pelvic pain, migraines, the whole laundry list of medical complaints, all of those sorts of things that are very difficult for physicians to figure out. Growing up that way instills a constant fear, a constant state of turmoil that's just under the surface of a veneer that's fairly thin. Little things become scary in an atmosphere like that, and once you've internalized all of that, it's very difficult to let go of it.
In the next slide, you'll see the relationship of A-score and the likelihood of perpetrating, of causing domestic violence. Now, we're usually used to thinking of women as the victims of domestic violence, but that's simply because their victims are their children, who are not in much of a position to make this known. But when one looks into it carefully, you see that more or less about equal prevalence and a distinct relationship to underlying A-score. On the next slide, you see how it plays out in the workplace. Relationship of absenteeism to underlying A-score. Relationship of self-acknowledged serious problems to underlying A-score, Relationship of having serious self-acknowledged problems performing my job properly to underlying A-score. So as you'll see here in the next slide, we saw that adverse childhood experiences determine the likelihood of the 10 most common causes of death in the United States. And the things that we've been looking at really are the risk factors for the 10 most common causes of death in this country. We saw that with an A-score of 4 or more in the next slide, the majority of adults have multiple risk factors for these diseases, or have the diseases themselves, or have died already. And here you'll see that many chronic diseases in adults are determined decades earlier in childhood, not by childhood diseases any longer, but by life experiences. This has been a huge change in the past century. You know, you think about it, rheumatic fever, polio, diphtheria, rickets, pellagra, those are gone. Those are gone. What's going on now is so heavily the relationship to life experiences in childhood. Next slide shows that the risk factors underlying these diseases are often effective short-term coping devices. Buying antidepressants on the street, smoking 3 packs a day, eating to feel better, becoming obese, etc., drinking. And so we saw in the next slide here that there's this major public health paradox that many of our most common and intractable public health problems are also unconsciously attempted solutions to personal problems that go back to childhood, but that are lost in time and then further concealed by shame and by secrecy and by social taboo. So next we see that evidence from the ACE study shows that adverse childhood experiences are the main cause of so-called health risk behaviors, of disease, of disability, of premature death, and of healthcare costs. In fact, we have a recent article out showing that at A-score 6, there is on average almost a 20-year shortening of life expectancy. That was, again, a real surprise. How does this occur? Why is this so difficult to deal with? Well, look at this next slide. These are PET scans, a very sophisticated kind of X-ray that shows biochemical activity in various organs. Here we're looking at the brains of 2, 3-year-old little boys. Kid on the left, normal kid, ordinary life, normal PET scan. Kid on the right, 3-year-old little boy taken from a Romanian orphanage, institutions where the inmates were subjected to extraordinary levels of neglect and isolation. They were fed and so forth, but extraordinary levels of neglect and isolation. And you see a very big difference in blood flow patterns in the brain. Large areas of brain where there's no color, where there's no biochemical activity going on, essentially no normal blood flow. And I don't think it's going to tax anyone's imagination to think that maybe at age 3, when brain is being formed, this is going to have some effect on the kind of brain that's being formed. In other words, what we're looking at is the translation of life experience into neuroanatomy. And maybe that has something to do with why this is so difficult to deal with after it occurs. So we can summarize what we've been looking at this way on the next slide here. This huge base of people on the next slide with adverse childhood experiences. Oh, go back one, please. With adverse childhood experiences, mainly unrecognized. We realize now that these cause disruptions in brain development and various kinds of impairment, social, emotional, learning impairment. And when those individuals become teenagers, they have enough freedom to try to do something to feel better. There might be smoking, drinking, street drugs, promiscuity, etc. It's those things that help in the short term, given time, produce disease and disability and social problems. And a lot of people die early, and the whole sequence is lost in time. So here we then pose, in the next slide, the question, how do we get from where we are now to where conceivably we could be? Two things would appear to be necessary. One is recognition that these problems actually exist, commonly exist. And two would be routinely to recognize them in medical practice. Next slide shows where this study was carried out, where we have this unusual operation going on, providing very detailed medical evaluation to large numbers of adults, actually to 1.25 million individual patients since 1975. And here in the next slide is the picture of the medical history questionnaire that is step 1 in this process. This is all filled out at home. Very important, at home, not on some damn clipboard in the doctor's waiting room. And here is some additional questions in the next slide to what we asked in the ACE study. I mean, the 10 that we pursued, the 10 categories, are not the only 10, so we added some other ones. Have you ever lived in a war zone? Ever been a combat soldier, etc.? Who in your family has been murdered? So on. And in the next slide, here's a picture of what we learn from patients. These are excerpts from actual person's medical history questionnaire. When we get the 10-page questionnaire back, we put it in a digital scanner that picks up all of the yes answers and prints them out in the nice, highly legible output. so that in 2 or 3 minutes of looking at this before meeting a patient, we really learn an extraordinary amount. And the way we use this in the exam room will be to say to a patient commonly, I see on the questionnaire that, can you tell me how that's affected you later in your life? And listen. I see on the questionnaire that you were the one who discovered your father's body when he hanged himself. Can you tell me how that's affected you later in your life? I see on the questionnaire that you were molested a number of times as a kid. Can you tell me how that's affected you later in your life? And we listened, period. After we were doing this for a couple of years, a German mathematician from the University of California came by. He had a startup data mining company, and he offers to do a 130,000 patient study to see whether the addition of these trauma-oriented questions has any meaningful effect. 130,000 people is 2.5 years throughput for the department in terms of the medical evaluation. And incredibly, he found that it triggered a 35% reduction in doctor office visits in the next year compared to the year before for that group, and an 11% reduction in emergency room visits. I mean, this is staggering. And we had as a control group, a much smaller sample, but nevertheless a control group, the same physical exam, same laboratory studies, same medical history, but without the trauma-oriented questions, led to an 11% reduction in doctor office visits in the subsequent year, and we were very happy with that. But 35% reduction in a sample this size is really extraordinary. The implications for this in terms of the costs of medical care are staggering. Keep it in mind because no one has exploited this yet. The question is, how does this come about? I mean, many people hearing this say to me, 35% reduction. How'd you do that? You sent everyone to therapy, right? No, we essentially sent no one to therapy. Well, how'd you do that? We spent a lot of time thinking, how did we do that? And ultimately realized that the piece that we had not clearly recognized was this: asking initially by an inert mechanism, and then following up on that in the exam room, and listening, and implicitly accepting, period. Enabling someone to tell a person who's important to them one of the deep secrets of their lives, typically for the first time, and realizing that they're still acceptable to this person, a huge de-stressing effect. A huge de-stressing effect leading to a 35% reduction in doctor office visits. The dollar value of that is mind-boggling. So I'll summarize this way. What did we learn in the ACE study? In the next slide, you'll see this summary. That adverse childhood experiences are common, but typically unrecognized. Their link to major problems in life is strong, proportionate, and make sense. They are the nation's most basic public health problem. And it's comforting to mistake intermediary mechanism for basic cause. The reason kids are fat is that damn McDonald's is doing it. The reason my kid's buying that crystal meth on the street because there's a dealer on the next block. It's a lot easier to say that than it is to say my kid's buying antidepressants on the street. Really? Why? Not a comfortable question. That what we see as the problem may in fact be somebody's attempted solution, like buying antidepressants on the street. That unwittingly treating the solution may be threatening and cause people to flee treatment. The primary prevention, keeping these things from happening in the first place, is presently the only feasible population approach. And interestingly, these changes have been resisted by us in spite of enormous benefits. If you want further information about all of this, I'll provide you some locations on the last slide, but here in the next one, you'll see that, next slide. Okay, well, here, this is fine. Further information, places where you can learn more about the ACE study on the internet and also on YouTube. So it's your time to talk now, to have questions. We have time set forth.
Well, thank you, Dr. Felitti, for your very interesting and thought-provoking talk. We now have about 10 minutes for some questions and answers. So please, there will be a microphone that will be passed around for those who have any questions you would like to ask Dr. Felitti. This is a very good opportunity to have some of his vast experience and wisdoms given out to us even further. Here's a question.
Hello, I'm Veronica and I'm a midwife, and I would just like to thank you for this very interesting talk. And I'm just curious about, and I would like to hear you elaborate on how the high ACE score correlates with the risk of being raped. If you could do that.
There are enough women in the audience that I think it would be quite useful to have people in the audience offer their thoughts on that.
Well, I wondered when you talked about that, whether possibly women who have had these experiences are more likely to be in environments that are unhealthy, like in the, doing drugs and that kind of environment, and that increases the risk of being raped.
I think that's a very well taken point. Any other thoughts? Well, something to think about is that...
There's one quick question
Yeah.
One
here.
more, one more comment.
Hey, thank you for... my name is Binna. I'm a counselor. I was wondering, is there a possibility of the 35% decrease of people coming back that you talked about at the end, that a part of them are just uncomfortable because all of a sudden you're asking about uncomfortable things, even though they are willing to answer in a questionnaire, that all of a sudden somebody will start talking about it with them?
Well, absolutely, well taken point. It overlooks, however, the possibility that anyone who is so uncomfortable with that could have avoided it totally by just lying and marked no on the questionnaire. So that would be one answer. Another answer is, with a sample of 100, well, we have now done this with 440,000 adults over an 8-year period undergoing comprehensive medical evaluation. We have had 0 patient complaints about the questionnaire, and I have a stack of letters complimenting us on the questionnaire. One memorable one An elderly woman writes, "Thank you for asking. I feared I would die and no one would ever have any idea what had happened."
Okay, there's one more comment or question.
Hi. I'm wondering, a person that has been abused as a child and grows up to have diseases, is that person, does it have any less disease just because they have been abused, or a person that has not been abused? Do you understand what I'm trying to say?
I missed a key word in your question. A person who's been abused as a child and grows up has...
Yeah, I'm just maybe regarding the past, for example, for women in history. And
No, help me understand your question. I missed one word. I didn't understand one word. And grows up and has what?
Am I, for example, less sick, or should be not treated with the same respect as someone who has not been abused? Or if I am abused, do you get what I'm trying to say? There are two people have the same disease.
Still, I don't get what you're trying to say, because you have left out a key word in the first question that you posed, and grows up to have.
Okay, two people. One was abused as a child and another not. They grow up both to have the same disease. Is there a difference in their disease regarding should they be taken equally as seriously, because maybe it has something to do with mental?
Oh, okay. Basically, I think the answer would be no, because most of the time the history of abusive experience is not known. Most physicians do not seek this information, so it is not known. I mean, what we did here was really to ask questions about things that typically are unspeakable and hence unrecognized, so that the very basis for treating people differently would not exist, because the difference is not recognized.
Okay, are there any more comments or questions? We still have about 5 more minutes. Okay, yeah, there is another one.
I was wondering if there is anything that you could do after you are an adult to try to decrease the chances of getting those diseases, or anything that can come of these adverse experiences?
Yeah. Yes, I think it's clear that helping a person speak openly to another individual is a very useful device. Now, that might involve psychotherapy. I mean, I am a strong proponent of psychotherapy. The problem is that it's unaffordable to most people. So we paid a lot of attention to what would be affordable. A man named James Pennebaker, Pennebaker, has written extensively on the benefits in medical settings of autobiographical writing. You can look his name up on Amazon and see some of his books. And I've used that, and I'm a firm believer that that's really helpful. I'll often tell people, look, before you come back and see me, I want you to send me a detailed autobiography of the first 5 years of your life, and then we're going to move forward in 5-year segments. We found that medical hypnosis, if you can find an experienced hypnotherapist, can be a very useful tool, because quite frequently a dramatic change can be produced in one or two sessions. The new form of psychotherapy known as EMDR also has the same benefit that significant improvement is often attained in several sessions, so hence becomes affordable. Now, in terms of what impact those have on disease formation, that's a harder question that has not been studied. Someone would have to set up a long-term follow-up to look at that. Important question, but not yet answerable.
Thank you. Are there any further questions? I would like, well, there's one. Yeah, great.
Yeah, hello, Bertrand. I'm a trial psychiatrist. I was wondering if has it been tried to refine the ACE score, not only counting the number of adverse experiences, but number of kind of adverse experiences, but taking account, for instance, to the severity of each adverse experience. We know, for instance, that in child sexual abuse, the age of onset, the number of experiences can have a strong impact, the response of the family also. Can you comment on that? Other kind of counting?
No, I think what you're saying is quite correct, but my partner at the CDC, Dr. Anda, was perceptive enough to realize that what we were uncovering was going to be very disturbing to a lot of people who would try to make it go away. And one of the ways they would use to try would be to say, come on, you really mean that 50 years later you can reliably say to someone that something happened 11 times versus 13 times? I mean, this data is just not reliable. Get rid of it, forget it, etc. So we made a conscious decision not to attempt to study events, the number of events, but simply the existence of the category. Your point is well taken. The earlier in life these things occur, the more damaging they're likely to be, and the reasons for that are interesting. But we specifically chose not to attempt to count, to tally events so long after the fact, in order to avoid people dismissing the data as being unreliable.
Well, it's now 6 o'clock and it's time to stop. I'm really thankful for your talk, Dr. Felitti, and I want to thank all the audience for being here and for all the interesting questions you've raised. So I guess it's just thank you all and goodbye for now.
Well, thank you.
Thank you.